Perfect. Thank you for reminding me. Oh, okay. Asians have a higher risk of hypertension, developing cancer of the liver, and they tend to be more lactose intolerant. Native Americans and Alaska Natives suffer more with heart disease, cirrhosis of the liver, which can turn into liver cancer, diabetes, and fetal alcohol syndrome. Hispanics suffer more with diabetes and lactose intolerance, and then Eastern European Jews, they are more susceptible to cystic fibrosis, spinal muscular atrophy, and a disease called Tay-Sachs disease. So we know that these are what we just talked about. They're examples of common health problems in specific populations. We need to recognize that these are risks for overall groups depending on ethnicity, and we need to be able to educate them about disease states that are prevalent in their culture. This is not considered stereotyping because we know that these are actual issues that can happen with our patients. So all the things I just talked about are in your book. You need to be familiar with them, okay, because you're going to see them on the exam. So when we educate our patients about
Professor Davis, I do apologize. Ashley's waiting to be let in.
Thank you. So she is not there right now, but if she comes back, just, oh, wait a minute, now she popped back in. Thank you. So when we if we have a patient that is an African American, it is completely acceptable to educate them about the risks of hypertension because it is something that they have a higher chance of developing. So that is not considered stereotyping. Okay, so I want you guys to remember that. Cultural respect. So having respect for each patient's different cultural background enables us as nurses to be able to provide care that is going to be culturally respectful. We will plan their care and implement it in a way that is very sensitive to their needs, not only the patient, but their families. And anyone that accompanies them to the hospital. It does involve us as nurses demonstrating knowledge and understanding of your patient's culture. You need to understand what their health-related needs are, and then you need to know specific illnesses and health needs that are going to be specific to their particular culture. Not assuming that the healthcare provider's beliefs and values are the same as the patient is something that we don't want to do. Just because we feel a certain way about something doesn't mean that our patients feel a particular way about something. And then we want to resist having those judgmental attitudes, okay, when we're thinking and recognizing how other people view their health. We do need to remember that patients from different cultural backgrounds, that they have different preferred communication. So when we are talking to them and educating them about medications or procedures, that we need to use their preferred method of communication. We need to be very aware of their dietary preferences. So when patients come into the hospital, we know how important nutrition is so that they can heal and get better. But if we're not meeting their needs, and giving them, so for instance, patients that are of the Jewish culture, they have to have a certain diet. We need to advocate for them and make sure that we can get them a kosher diet. So if it's not listed on the menu, make a phone call to the dietary and say, hey, I have a patient that's requiring a kosher diet. Can you please send me up the menu? So make sure that they are able to obtain their dietary preferences. And then also we need to think about dress. So normally when patients come into the hospital, we prefer them to wear a gown just because if anything happens in an emergency, we need to be able to get to them quickly. In some cultures, it's not appropriate for them to wear gowns in the hospital, especially women. So we have to be respectful of them and allow them to wear what they need to be so that they can uphold their cultural beliefs. Okay, that's important as well. You guys need to know that. Okay, so within cultures, we always find little subcultures. Okay, subculture is a large group of people who are members of the larger cultural group, but who have certain ethnic, occupational, or physical characteristics that are not common to that larger culture. Most of our society includes both dominant culture groups and minority culture groups. The dominant group has the most ability to be able to control the values and the sanctions of the society. It usually is the largest group in the society. It doesn't have to be, but it usually is. And then minority groups usually have some physical or cultural characteristic. Such as their race, their religious beliefs, or their occupation, different from those of the dominant group. When a minority group lives within a dominant group, many members may start to lose their cultural characteristics that at one time used to make them different. And they may decide that they're going to take on the values of the dominant culture. They may not even realize that that's happening. When this happens, we call that cultural assimilation. So when people migrate and encounter a new dominant culture as they work, go to school, and learn the dominant language, they often move closer to that dominant language. Does that make sense to you guys? Sometimes when we're placed in a different culture that we perceive as strange, we can actually experience culture shock because it's not something that we're used to. It's something that's completely different. Culture shock can result in psychological discomfort, psychological disturbances, because the patterns of behavior a person find acceptable and effective in his or own culture may not be adequate or acceptable in the new culture. So that would be culture shock. So when we talk about ethnicity, ethnicity is a sense of identification with a collective cultural group, largely based on the group members' common heritage. One belongs to a specific ethnic group or groups either through your birth or through adoption of characteristics of that group. People within an ethnic group generally share unique cultural and social beliefs and behavior patterns. That includes their language, their dialect, any type of religious practices, literature, music, your political interests, food preferences, and even your employment patterns. And ethnicity largely develops through day-to-day life with family and friends in the community. And it's learned from a young age. So when we talk about the term ethnicity, it is often used interchangeably with race. I hear a lot of people using them interchangeably, but they are not the same. So racial categories are typically based on specific physical characteristics such as skin pigmentation, your body stature, your facial features, and your hair texture. There are federal standards for race classification. There's actually 5 categories. The 5 categories are American Indian, Alaska Native, Asian, Black or African American, Native Hawaiian, or other Pacific Islander, and white. So those are the categories of race that are classified according to federal standards. Stereotyping. When one person assumes that all members of a culture, an ethnic group, or a race act alike, that is considered stereotyping. We see this all the time, every day. Some people don't even realize they're doing it because it happens so much. Stereotyping can be positive or it can be negative. So negative stereotyping would be racism, ageism, and sexism. These are mistaken beliefs that certain races a certain age group or one biological sex is inherently superior to others. When that happens, it leads to discrimination against those that are considered inferior. As nurses, we need to make sure that we're providing care that is respectful and free from biases. We need to look at our practice and our own prejudices and realize how we feel about certain things. That's the first step for us being able to eliminate any biases that we have. Sometimes you don't even realize that you have biases. I see patients that will come in and into the emergency room, and you will deal with a lot of people who have drug issues in the acute care hospital setting. It's an epidemic. So you're going to see that. But sometimes when people start to see it so much, they start to stereotype people. So if someone comes in and they have tattoos and they're asking for a lot of pain medicine, they might automatically say, oh, well, they're a drug addict, they're drug seeking. I see that all the time. So these are the things that we need to be aware of. We need to look at our practice. We need to look at the way we think about things, because that's where these stereotyping, that's where that begins, within our mind and our thoughts. So we need to identify prejudices. That is going to be the first step in order to eliminating them. So some cultural terminology. So cultural imposition, this is when the belief that everyone else should conform to your own belief system. So that is that you believe everything is right, and everybody else's way of doing things is wrong. So cultural imposition. Cultural blindness, this occurs when one ignores differences and proceeds as though they don't exist. So you notice that there's differences, but you ignore them and you just pretend like it doesn't even happen. We do see these in healthcare when it comes to some of our non-traditional methods of care. So we need to be, again, aware of them and make sure that we are not contributing to them. Cultural conflict occurs when people become aware of cultural differences. They feel threatened and they respond by ridiculing the beliefs and traditions of others to make themselves feel more secure about their own values. So this is important. I want you guys to know what cultural conflict is, because you guys are going to see that again. And then we have ethnocentrism. So this is the belief that one person's own ideas, beliefs, and practices are the best, they're superior, or the most preferred to anyone else's, using one's cultural norm as the standard to evaluate others' beliefs. So whatever I believe in is the best. There's no other way to do it. Your way is not acceptable. It's my way or the highway. So when healthcare professionals assume that they have the right to make choices and decisions for patients of another culture, patients may respond in the same way that minority cultures often respond to such an attitude by the dominant culture. They might become passive, they might be resistive, they could be angry, and then they become resistant to treatment. So we have to remember that even if a patient is doing something that we don't agree with, that we wouldn't do for our own self, we have to respect our patients' wishes, and we have to advocate them and support them, because it's what's important to them. And that can be hard sometimes, especially when it's something that you don't believe in. And it doesn't mean that you have to believe in it. We all have different beliefs, and that's what makes us unique, and that's what makes the world go round, and everybody can believe what they want to believe, but we have to be respectful of each person's beliefs. So in culture, we're going to talk about cultural influences on our healthcare. So we see physiologic variations. So we talked just a couple of slides back that studies have shown that certain racial or ethnic groups are more prone to certain diseases and conditions, okay? So when we talk about reactions to pain, so the expressions and behaviors that people exhibit when they're in pain can differ based on culture. So some cultures allow patients to encourage the open expression of emotions. related to pain, where other cultures require that you keep it suppressed and that you don't let any emotion out. So as nurses, we need to respect the patient's right to respond to pain in his or her own manner. We don't ever want to stereotype a patient's perception of or their responses to pain because of their culture. So this is, if we're giving out examples, this is something that I have to look within myself about all the time when I work, because when I have pain, I would never think about screaming out loud. Like even when I was having my kids and I was in pain, I would just turn my head, I would cry, and I didn't want to cause a scene. I didn't want anybody to pay attention to me. So when I see patients that are throwing themselves on the floor, screaming at the top of their lungs, that always seems bizarre to me. But I have to keep in my mind that this is not how they handle pain, Just because I don't handle pain like that doesn't mean that they can't handle pain like that. So we all have these feelings about different ways that people handle things. We just have to be aware of it, and we can't let it affect the care that we give. When we talk about mental health, there are many ethnic groups that have their own norms and their acceptable patterns of behavior for psychological well-being, as well as normal psychological reactions to certain situations. So many people, for example, in the Hispanic culture, they deal with problems within their family, and they consider it extremely inappropriate to tell anyone outside of the family about their issues. So they probably would not be very willing to seek treatment from a therapist outside the house, because that goes against what they believe their culture believes. And then some traditional Chinese people consider mental illness a stigma, and they believe that seeking psychiatric help can be a disgrace to the family. So these are the things that you need to think about when you're taking care of these patients from these different cultures. Gender roles, in some cultures, the man is definitely the dominant figure and generally makes all the decisions for the family members. So this could be difficult if the woman or the wife is the patient. It's very hard sometimes when you try and communicate with the patient, but another family member constantly makes the decisions for them. But we need to understand in certain cultures that this is expected and this is the way that it will be. There are also other cultures where women are definitely the dominant. So we just need to, again, understand that when we are providing care. When we are communicating with our patients, in the United States, we have a very diverse population, and we have a lot of different languages that are spoken. And it's very easy for communication problems to arise. So we just need to be aware of that and make sure that we are communicating in a way that they will understand. We want to make sure if we are giving them discharge instructions or education about medication, that it's in a language that they can understand, including their family members when we're teaching them as well. Something else that's important for you guys to know, there are some patients of certain culture that do not make eye contact with a nurse when they are talking. This is a completely acceptable trait in the Hispanic culture. It is not considered disrespectful. It's completely accepted. So you guys need to think about that when you are sitting down with your patients. We always tell you to get on their level, sit with them, make that eye contact. It makes them feel like they can trust you and that you're really present and there with them. But in this particular culture, they will not make eye contact with you. So that is an important question. You guys are going to see that on your exam. We also have to be careful about orientation to space and time. So personal space is something that we always have to be very, very respectful of, especially now with COVID. This personal space area is very individualized for each person, and it can be very different for different cultures and ethnic groups. So in some patients, it might be okay for you to sit on the side of the bed, put your hand on their arm, put your hand on their knee. That's completely okay. Where in other groups or of culture, that's not acceptable. They don't want you to sit on their bed. They don't want you to touch them. That's considered, it's offensive. When we think about food and nutrition, again, we have to think about those food preferences. How do they prepare their food? When patients are in the hospital or a long-term care setting, they don't always have an option of much food choices. So calling down and getting that kosher diet, or making sure if they're lactose intolerant that they have lactose-free milk. You can even encourage family members to bring in some of their favorite food and keep it in the refrigerator and bring it out at dinner or lunchtime and heat it up. So that way they have their food so that they can get the nutrition that they need. So this is another thing. If you have a patient that you're taking care of that is refusing to drink or eat, it might not just always be that they don't feel good or they don't feel like eating. You need to like dig a little bit more and say, well, do you feel hungry? What are you hungry for? Do we not have the food you want? Is there a particular drink that you want? They might not feel comfortable telling you that the food that's here is not culturally appropriate for them. So you guys need to recognize, hey, something's going on with their diet. Let me do a little bit more digging and find out what's going on. Maybe we just don't have the food or the drink that they need. And then we think about family support. So in many cultural and ethnic groups, a lot of people have very large extended families, and they consider the needs of their family member to be equal or even greater than their own. So we want to have respect for all of their family members. We want to make sure that we're giving updates to at least one family member a day, keeping them on board with what's going on with their health, especially now that we're in COVID, when patients can't have visitors. The only thing that we can really give them is a phone call each day to update them on their loved one. And then socioeconomic factors. We know that for a long time, poverty has been a barrier to adequate health care. It prevents many people from being able to consistently meet their basic human health needs because they don't have insurance. If they have insurance, they don't have transportation. There's a variety of socioeconomic factors that influence people being able to adequately get the health care that they need. So one thing I hear from a lot of nurses is, or new nurses, or when I'm teaching this topic, is that, how do we know all these things? And I remember feeling like that as a new nurse. How in the heck do I know about all these culturally, competent issues when I've never taken care of these people? So we don't expect you to know everything. We just want you to recognize that there are differences. We want you to recognize there are differences and then respect those differences. And you can always go to another nurse on the floor and say, I'm taking care of a Jewish patient today. Have you ever taken care of a Jewish patient? Can you tell me about their diet again? I just don't remember a lot about it. It's completely okay to ask. You can even Google things. Google is your friend. I know we've talked about that before, but just rely on those older nurses and other people that you work with, and they will be able to help you. So this is culturally competent nursing care for the patient in pain. So we need to be able to recognize that each person holds various beliefs about pain, and that pain is exactly what the patient says it is. So if you go into the patient's room and the patient says she has abdominal pain and she's tearing and she's shaking and her blood pressure's through the roof and she's bent over and she's guarding her stomach and she's rocking back and forth, okay, you might say, oh, I believe it. She has a 10 out of 10 pain. You also may go into the next room and that patient, you say, what's your pain level? 10. And they're just sitting on the side of the bed. Maybe you woke them up. Maybe they were sound asleep. They're completely comfortable. They don't look like they're in pain. If the patient says their pain is a 10 out of 10, the pain is a 10 out of 10. Okay, we have to respect the patient's right to respond to pain in one's own fashion. So one person might cry, one patient may scream at the top of their lungs, another patient may just roll over and look the other way, and they might not ever even say anything to you about their pain. So we all respond to pain in a different way. We never want to stereotype a patient's response to pain based on the patient's culture. So not everyone of the same culture will respond to pain the same way. We need to be sensitive to nonverbal signals of discomfort, such as holding or applying pressure somewhere to a certain painful area. avoiding certain activities. If a patient came in because they had a fall at home and they landed on their hip, and then it's an older patient, they need to get up to go to the bathroom, and you say, okay, Mrs. Jones, I can help you to the bathroom. You know what? That's all right. I'm just going to use the bedpan. Well, why do you want to use the bedpan? Oh, I just feel more comfortable doing the bedpan. Well, that's not really comfortable. We want you to get up. We want you to go to the bathroom. Well, it's going to hurt if I go to the bathroom. So you want to just try and look at those nonverbal things, and then be aware of issues that intensify pain. So again, getting out of bed and walking to the bathroom, does that make that hip pain worse? Trying to have a bowel movement, does that make the abdominal pain worse? What causes the pain to increase? All right, so in some cases, the culture of poverty can be passed on from generation to generation. This is especially true in such groups that come from migrant farm workers, families that live on public assistance, and people who live in isolated areas. Poverty cultures usually have a couple of the same characteristics. They have feelings of despair, resignation, and fatalism. They have a day-to-day attitude towards life with no hope for the future. So they're really literally are just going day by day. They can't see themselves getting out of this situation. They feel trapped, and they don't feel positive that in a couple days or a couple months or a year in the future that things will be better. They may be unemployed, and they might have a need for financial or government aid. They might have an unstable family structure at home, which could be characterized by abusiveness and abandonment. So when there are issues with employment and not being able to provide for your family, bringing in money, having food, that kind of stuff, that puts a lot of pressure on any family. It can cause your family, obviously, to be unstable. It can put a lot of stressors in there. Things can get heated. So these are some of the things we kind of have to look for in the hospital setting as well, being able to recognize these opportunities. And then we also see that there is a decline in self-respect, and then they retreat from the community involvement. All right, so elements of cultural competence. So in order for us to become culturally competent, we need to develop self-awareness. Well, what is self-awareness? There's all those things that we talked about. Well, it's not normal. I don't feel like I could ever scream and cry when I'm in pain. Okay, that is me being aware that that is not how I would handle pain. But I'm also aware that this is completely acceptable for Mrs. Jones, and I'm going to help her however I can to calm her down and let her express her pain the way she wants to. We need to demonstrate that knowledge and that understanding of their culture. Again, it doesn't have to be, you don't have to agree with it. It doesn't have to fit your lifestyle or your needs, but you're acknowledging it and you're understanding it. And you're accepting and you're respecting cultural differences. So your cultural beliefs are different than mine, and I accept them, and I'm respectful of you and your preferences. We cannot assume that the healthcare provider's beliefs and values are the same as the client's. So just because I choose to eat a diet that is low in fat, high in protein, does not mean that other patients will. They have their own values. We want to resist those judgmental attitudes, such as different is not good. We want to be open to and comfortable with cultural encounters and having those conversations and recognizing the differences between you and the patient. And then we want to accept responsibility for one's own cultural competence. So what are the factors that affect culturally diverse interactions? So when nurses with a particular set of cultural values regarding health interacts with a patient of a different set of cultural values about health, there are factors, obviously, that are going to affect that interaction. So the first thing is going to be the cultural background of each patient. Our differences will affect the interaction that we have, the expectations and beliefs about healthcare. We need to understand that they could be probably different because we're both from different cultural backgrounds. The cultural context of the encounter. So where is it? Are we in the hospital? Are we in the clinic? Are we in the patient's home? And then the extent of the agreement between the two persons, set of beliefs and values. So what is the extent of our agreement? Am I working with you? Am I your nurse? Am I your home care nurse? Do I come to see you every 2 days? What is my extent of helping you? And have we decided to work together? And have I recognized your set of beliefs and made sure that I am modifying your healthcare to meet your needs? So, guidelines that we should use for providing culturally competent nursing care. Again, developing cultural self-awareness. You see this is in almost every single slide. So this is huge. We need to develop that cultural self-awareness. We need to develop cultural knowledge. So you guys will develop some cultural knowledge here, which you're learning, but you probably will forget some of this by the time you actually go out and go into practice, and that's okay, but you will learn it once you start working with patients again. We need to accommodate cultural practices in the healthcare setting. We need to respect culturally based family roles. We need to avoid mandating change. And then we need to seek cultural assistance. So when there's something that we don't know or how to handle something, then we need to reach out to other people to find out how we should be handling it. Cultural assessment areas that nurses need to understand. So the National Center, there's actually a National Center for Cultural Competence. They urge that healthcare professionals who value being able to offer cultural competence in their practice, they want them to enhance their understanding of these following areas. So they want you to be culturally competent in beliefs, values, traditions, and practices of cultures. They want you to be culturally defined, health-related needs of individuals, families, and then the communities that they come from. They want you to understand culturally based belief systems of the etiology of illness and disease, and those that are going to be related to the health and healing of the patient. Also, their attitudes towards seeking help from healthcare providers, because we said that can be very different for each culture. And then when caring for patients from a different culture, they want you to understand that it's important to first ask how they want to be treated based on their values and beliefs. This is an effective way to identify specific factors that influence a patient's behavior by performing a cultural assessment. So when we admit a patient to our floor at the hospital, we always have something that's called a database, and we ask them all these questions. Have you been out of the country? Have you traveled? Have you had immunizations? All this stuff. One of the things we ask them is do they require any cultural or spiritual needs while they're at the hospital? So that opens the door for you to be able to get your patient to acknowledge those needs that they may have while they're at the hospital. And I think almost every hospital has those included in their set of questions that they ask new patients when they come in. So when we talk about assessment and data collection, we are talking about the patient's cultural background. So we want to know, an example of information that we could get was that the patient was born in Central America and has been a resident of New York for 2 years. So this tells you where the patient lives now and where he came from, where he was born. When we inquire about the health and wellness beliefs and practices of your patient, an example would be that the client relies on folk medicine to treat or prevent illness. So based upon what they practice outside of the hospital, this is going to tell you how they're managing their healthcare needs. When we look at family patterns, an example would be the client is from a patriarchal culture where the oldest male family member makes decisions for all the family members. So you would know that when you see an older male in the room with your patient, with other family members, you will know that he is probably going to be the one who's making decisions for for that family member. So it won't catch you off guard when you're talking to the patient, but then this family member always makes the decisions. You'll understand that this is a normal, something that's expected from this culture. And then verbal and nonverbal communication. We have an example of that a couple slides back within the Hispanic culture. Some cultures believe that in the Hispanic culture that it's disrespectful to make direct eye contact. So those are just some examples. When we talk about that space and time orientation, so we want to know, about their, it talks about within the client's culture that they place little importance on how past behaviors affect future health. So some patients might not be willing to give you information about, do they exercise each day? What kind of meals do they eat? They're not going to think that it's important because they don't think that these things will affect their future health. When we talk about nutritional patterns, the client believes that some foods have healing properties. So they might take a food that is, maybe it's red meat. There's a lot of studies out there that show that there's a direct correlation with red meat and high cholesterol. But for certain cultures, they believe that it has healing properties, so they might consume a lot of it. So you might be able to educate them about what you know, but you have to be ultimately understanding that they might not be willing to change the way that they eat because of their beliefs and their culture. And then when we talk about the meaning of pain, within some clients' cultures, pain is viewed as a punishment for a misbehavior or a sin. And then death rituals. In some culture, they do believe that suicide is acceptable. Hopefully that's not something that you guys ever have to see in a clinical setting, but it's good to know. So we call this the 4 C's cultural assessment. These are things that we can ask our patients. So the 4 C's, what do you call the problem you are having now? How do you cope with the problem that you have? What are your concerns regarding the problem? And what do you think caused the problem? So if you're trying to get some information out of a patient, based upon why they came into the hospital, what is going on with them. This is a mnemonic for a cultural assessment that you guys could use, the 4 C's. All right, so we're going to talk about spirituality now. So the objectives are, we are going to be able to identify spiritual needs believed to be common to all people, describe the influences of spirituality on everyday living, health and illness, distinguish spiritual beliefs and practices of the major religions that are practiced in the United States, be able to identify factors that influence spirituality, and describe nursing strategies to promote spiritual health with our patients. All right. So there are 3 spiritual needs. They are, one is the need for meaning and purpose. So everyone needs to, according to Shelley and Fish, they believe that these 3 essential needs need to be met in order for each person to meet their spiritual needs. So every person needs to have the need for meaning and purpose. They need to feel like they exist for a reason, and they need to feel like that there is meaning behind the things that they do. The second one is the need for love and relatedness. So they need to feel love, they need to receive love and give love. And the third one is the need for forgiveness. And that goes both ways. So the need to forgive and then the need to also be forgived. So those are the three spiritual needs. So the spiritual dimension. So A is actually, so this is the spiritual dimension. This is like an integrated approach, which encompasses four individual values. So we have, they believe that with this certain approach, they believe that these four dimensions are equal and that each one will influence the other. It looks at psychological needs, spiritual needs, physiological needs, and sociological needs. And they believe that all of these need to be met and that each one affects the other one in order to meet, to be, for a person to have all of their spiritual needs met. So, whoops, mine's not clicking. All right, so this is just another slide, just another picture. This is your spiritual dimension on the outside, and these are all of the grounds that have to be met. So this is your sociological, your physiological, and your psychological, which is different from the last one that we saw, which had spiritual, right? Spiritual was just an equal component to the other ones here. All four of these were equal: physiological, psychological, spiritual, and sociological. Here, in this approach, the unifying approach, we have spiritual is the whole outside, and then inside is just these three dimensions that affect the whole spiritual outcome. So that's your physiologic, your psychologic, and your sociologic. These slides are in your book if you want to take a look at them. So being able to meet spiritual needs. So nurses can help patients meet their spiritual needs by offering a compassionate presence. So we can assist patients who are struggling to find meaning or purpose behind a certain illness. It could just be pain. It could be the diagnosis of cancer. It could be an ongoing chronic disease that they're dealing with, and it can even be death. We can facilitate the patient's expression of their religious or spiritual beliefs and practices, even though they might be different than ours. This is our job as a nurse, to be able to help those patients express those needs and make sure that their needs are getting met while they are in the hospital. So spirituality, the definition is anything that pertains to the person's relationship with a non-material life force or a higher power. So spirituality and higher power, a lot of people use those two interchangeably. Spirituality can play a very important role in a client's ability to be able to balance their life with regards to their health, being able to seek health care and deal with injury and illness. Spirituality has a big effect on that. Faith is, the definition of faith is a belief in something or a relationship with a higher power. Faith can be defined by a culture or a religion, so it can be different for each group of people. And then we have religion. So religion is a system of beliefs that are practiced outwardly to express one's spirituality. Religion can influence the client's response to illness and suffering. Their self-care practices, such as their diet and their hygiene, their birth and their death rituals, their biological sex roles, spirituality practices, and moral codes. So how people act morally. So I know myself, certain patients, certain people with a Catholic background, their religious beliefs will prevent them from having um, being in relationships or having sexual encounters with the same sex. It is believed in that religion that that is something that will not enable you to go to heaven. So this is a way that religion can affect the things that you do in your life, such as those biological sex roles. When we think about birth and death rituals, there's a lot of different rituals that different cultures do when a child is born. Some people get their child circumcised in the hospital, others it's performed at the home in front of family members once the baby comes home. And then there's different death rituals. So some people don't care at all when they die. They can be cremated and given to a family member. They don't care. Others, they have to have a viewing in a funeral home. Then they have to have a burial in a graveyard. Those are their different rituals. So there is a difference between all three of those, the spirituality, their faith, and the religion. So you guys should know the differences between each of them. So this just says, promise me you'll always remember you're braver than you believe, stronger than you seem, and smarter than you think. So this is just another form of spirituality, being able to believe in something, offering a kind word. So when we talk about hope, so hope is an ingredient in life that is responsible for contributing to a positive outlook. It's a concept that includes optimism, and it can provide comfort during a time of a crisis. It enables people to be able to consider the future and then actively work in their present life to be able to bring that future into play. Hope is not anything you can see. It originates in your imagination, but it must be, in order to put it into an action, it has to be valued. So you have to value it. It has to seem like a realistic possibility for you in order for you to put what you're hoping into an action. Hope does allow people to be able to embrace the reality of suffering without escaping from it, which was what we call false hope, or being suffocated by it. So being suffocated by it would be despair, helplessness, hopelessness. And then just like all the other things we talked about, hope is very unique to each person. Some people are just believers in everything. I believe that this is going to happen. I believe in the power of prayer. I just know if we say prayers that, Grandma Evans is going to make it through this. Some people are just like, nope, what's meant to be is meant to be. So hope is different for each people. Each person. When we talk about love, love is just the connectedness with others. There is a basic need to be loved and to give love. We cannot be spiritually whole or spiritually healthy unless this need is met. Spiritual health and healing or spiritual well-being is the condition that exists when the person's universal spiritual need for meaning and purpose, love and belonging, and forgiveness are met. So all of these needs are met. That is when it is considered that we have spiritual health and healing. Spirituality and everyday living. So these practices are associated with all aspects of a person's life. It includes their health and it includes their illnesses. It's any wisdom that helps us find meaning in life. It can be in relationships. It can be just with ourselves, in our work, with our health. We can put it into play when we're living with certain parts of uncertainty in our life, when there's things that we're dealing with that we're not sure of. If we're dealing with any kind of suffering, if we've lost a loved one, and then when we're dealing with certain transitions in life, such as marriage, birth, and then, of course, death. So, elements of spirituality. So, This was this theory was developed by Burkhardt and Nagai and Jacobson. They believe that there are certain elements that are necessary for spirituality. So they think that spirituality is experienced as a unifying force. They believe it's a life principle and that it is an essence of being. They believe that spirituality is experienced in and through the connectedness that we have with nature, with our environment and the cosmos. They believe that spirituality is expressed in and through connectedness with other people, not just our family members. They believe that spirituality shapes the self becoming, and it is reflected in our in one's being, knowing, and doing. And then they believe, lastly, that spirituality provides purpose. It provides meaning, strength, and guidance, and that it helps shape our journey in life. So, beliefs that are related to faith. So, we said earlier, faith is also a term that is used to describe a cultural or institutional religion, such as Judaism, Islam, or Confucianism. An atheist is a person who denies the existence of a higher power. So they don't believe that there's any higher power out there. They can't see it, they don't believe in it. An agonist is a person who holds that nothing can be known about the existence of a higher power. Atheists and agonists deserve respect for what they choose to believe, just as those who accept that they believe that a certain particular religion is right for them. So agonist always has doubt, always has questions. They challenge you to think with logic and reason. So, some people don't believe in God. If I say all day, I believe in God, if you look around, how could God not do this? Well, my son might come upstairs and say, there's no God. You don't have any proof that there's God. All the Bible's information is just, it can be interpreted by each person. It's all meant to be interpreted by different people, different ways. It was just a spark that caused all this. So that's an agonist, someone who is always putting that doubt out there and questioning what another person believes. And atheism, again, is no doubt, no question. They challenge you to disapprove their lack of belief. Okay, so you guys should know the differences between those two. So religious influences can be life-affirming or life-denying. So a religious influence that is life-affirming will enhance life. It will give meaning and purpose to existence. It will strengthen oneself and are health-giving and life-sustaining. Life-denying religious influences restrict or enclose life patterns. They limit experiences and associations. They also place burdens of guilt on individuals and are health denying and life inhibiting. Guide to daily living habits with regards to religious beliefs. So there are certain practices that are generally associated with healthcare that may have a religious significance for your patient. For example, many religions, like we said earlier, have different dietary requirements and restrictions. So they can't eat meat, or they can't eat meat and cheese and milk on the same tray, or they can't eat after a certain time, or they don't eat on certain days because they're fasting and they're praying. There are acceptable birth control practices that are determined by certain religious faiths, and are some also types of medical treatments that are acceptable and not acceptable. Religious beliefs may be a source of support. So many people seek support from their religious faith during a time of stress. I've seen many patients in the hospital that have their pastor or their minister come visit them in the hospital because it gives them faith and it makes them feel supported. This support is often vital to the acceptance of an illness. no matter what it is, if it's a terminal illness or if it's just a new diagnosis of diabetes. But it's especially important if the illness is going to bring a very prolonged period or a convalescence period. Or then again, of course, if it has a questionable outcome. Prayer, devotional reading, and other religious practices often do for the person's spirituality what protective exercises do for the body physically. And then a source of strength and healing. So many people have known to endure extreme physical distress because of a very strong faith. Patients' families have taken on certain rehabilitative tasks because they've had faith in the eventual positive results of their effort. And then a source of conflict. Sometimes religious beliefs can conflict with prevalent healthcare practices. So the example that we use here is the doctrine of the Jehovah's Witnesses. So they are prohibited from having blood transfusions. So if you have a patient that's losing blood, you have to treat them in other ways other than blood transfusions because they will not accept a blood transfusion. Some Navajos use lengthy religious ceremonies to cure certain diseases, such as tuberculosis. So this might be something that you may see in your hospital room if you have a patient that is diagnosed with tuberculosis. And then some people view illness as a punishment for sin, and they think it's inevitable, and they feel like they're deserving of it. So they might not take any steps to prevent the pain or stop the problem from happening because they feel like they deserve it. So, of course, with anything, there are always factors that affect spirituality. So developmental considerations. So children definitely are on the end of the spectrum along with older adults. So when children are little, they don't know exactly what to believe. They basically follow what their parents or their whoever their caregivers are at the time, what they're telling them, what they're molded to think. But as the child starts to mature, they start to experience different things in life. These experiences start to influence and mature that child's spiritual beliefs. And then as you get older into your late teens, early adulthood, you start to think about life after death. And then this causes you to re-examine or reaffirm your spiritual beliefs. And then you believe what is important to you. Just like we said, a family is very important in the development of a child's spirituality. What those parents teach a child about spirituality and religion is what they're going to know as a child. And then as they get older, they can make up their own mind. Ethnic background also affects it. Different religions, traditions differ among different ethnic groups. Formal religion, so each of the major religious groups discussed earlier, share several characteristics. They all have a basis of authority or a source of power. They also each have a scripture or a sacred word. They all have an ethical code. So an ethical code defines right and wrong. That's important. You guys need to know that. You can find this in your book on page 1801. They each have a psychology and an identity so that it's inherent. It fits into a group, and then the world is defined by that religion. It also has aspirations and expectations, and then it also talks about what is to come when death occurs and what will happen to the body after death. So those are all the characteristics of a formal religion. Then we talk about life events. So there can be positive and negative life experiences that can affect our spirituality and how we feel about things. And these experiences, good or bad, will influence, what we think and what we attribute to why we feel like we do. So your book gives a good example. If two women who believe in God both lose a child in a car accident, one could be very bitterly could be very bitter about it and decide that, question God's existence and say, why would God do this to me? Whereas another woman who lost their child but also believes in God will just believe that it happened for a reason, that God's with her, God will protect her, and God will see her through. So there's definitely positive ways to view it and negative ways based upon your religion. So there have been different studies on children that were interviewed with different religions that revealed that children have definite perceptions of God. Central themes in all the studies with children described the following. So they believed that there was a notion of a God who works through human intimacy and the interconnectedness of lives. They believe that God is involved in self-change and growth and transformations that make the world fresh, alive, and meaningful. They believe that the attributing to God tremendous and expansive power and then showing considerable anxiety in the face of his power. And then they believe God is an image of light. So these are some pretty big perceptions, but based upon these studies, this is what they gathered that a child perceives of God. These are just some examples of some nursing diagnoses that we could give our patients. So there could be spiritual pain, maybe if they were just diagnosed with maybe a terminal illness or a chronic illness that they think is going to be debilitating. It could be a family member who lost a loved one. It could be spiritual despair, spiritual loss, anger, guilt, anxiety, and alienation. So nursing diagnoses for spiritual problems, we have readiness for enhanced spiritual well-being, and then we have risk for spiritual distress. So I want you guys to remember this: when patients get sick, this increases a patient's spiritual concerns. They may have had thoughts about spirituality before, but when they have an illness where they feel like they might not live or they're scared, it brings about those feelings even more, and they start to think about it. It can be very difficult for patients to put to express the words that they're thinking. You might just come into the room and find your patient upset or crying, reading the Bible, writing down things in a journal, talking with their pastor. These are all signs that a patient may have some type of spiritual distress. They might not be telling you what's going on, but you might be able to recognize it from the patterns that you observe in your patient. So you just want to be aware that patients are at risk for that spiritual distress. So patient goals and outcomes, we want to be able to identify spiritual beliefs that meet needs for meaning and purpose, for love and relatedness, and also for forgiveness. We want to be able to derive strength, hope, and comfort from the beliefs. We want to be able to develop spiritual practices that nurture communication with the patient's inner self, with God and the world, if that's what they believe in. And then we want to express satisfaction with compatibility of spiritual beliefs and everyday living. Whoops. And then patient goals and outcomes that we would want to see for a patient in spiritual distress. We want to explore the origin of spiritual beliefs and practices. So we want to talk with the patient and find out what they believe. What are their spiritual beliefs? What are their practices that are important to them? You want to identify factors in life that challenge spiritual beliefs. You want to explore alternatives to these challenges, identify spiritual supports, and then report or demonstrate decreased spiritual distress after you had your intervention. So when we're implementing spiritual care, we want to make sure that we are offering a supportive presence. So being supportive, we go into the patient's room, we give them time to talk, we listen. Sometimes we don't have to say anything at all. We can sit in the chair in the room, really be present with them, really listen. We want to facilitate the patient's practice of religion. So if they have to pray for a certain amount of time during the day and that time happens to be mid-afternoon, you would want to be respectful and not schedule any tests or procedures during that time. Because even though the patient is, unless they're critically ill, obviously, but if they're stable, then we would try and schedule things in the morning or later in the afternoon so that they are still able to meet their religious needs. We want to nurture spirituality. So we want to talk with them and find out what's important to them and make sure that we are helping them think about ways that they can nurture their own spirituality. We can pray with the patient if they want us to, and if it's something that we believe in. We want to be able to counsel the patient spiritually. And then if we need to contact a spiritual counselor, every hospital has a spiritual counselor, and we can always have someone come up and talk to the patient. So when we are facilitating the practice of religion, we want to make sure that we familiarize the patient with religious services within the institution. I know our hospital has a chapel that you can go to, obviously not right now because of COVID, but if it was post-COVID times and patients could leave their rooms, they could always go down to the chapel if they needed to. We want to be able to respect the patient's needs for privacy during prayer. So if we know that between 10 and 11, they're doing their prayer, we don't want to just bust through the door at 10:15 and say, Mrs. Jones, I have all your meds for you. We need to be respectful. So we need to go to their room before that time or make sure that we put a do not disturb sign on the door so that no one else disturbs them, and then go in after we know their prayer is over. We want to be able to assist the patient to obtain devotional objects and protect them from loss or damage. So if a patient is in the hospital and they would like to have a Bible, we can contact spiritual support and have them bring one up. We should respect it just like we do their wallet, their keys, their belongings, make sure that it's safe and put away so that it doesn't get damaged. We can arrange for the patient to receive sacraments if desired. They go around on all the units and offer communion on Sundays. We can attempt to meet those dietary restrictions. It might be hard to meet all of them, but we can always fall back on family members if we can to have them bring in those special needs, special meals for the patients. And then we want to arrange for a priest, a minister, or a rabbi to visit with the patient if that's what the patient wishes. And we have that in the hospital as well. We can arrange for that. All right. So when we are counseling the patient's spirituality, we want to have the patient articulate their spiritual beliefs. So what do they believe in? What is important to them? We can't help them if they don't know what their beliefs are. We want to be able to explore the origin of the patient's spiritual beliefs and what their practices are. We want to identify life factors that challenge the patient's spiritual beliefs. We want to explore alternatives when given these challenges. So we know when patients come in, they're in the hospital, they're sick, they have an illness. It could be an ongoing chronic illness. It could be the diagnosis of a new acute illness. This can affect the way they feel about certain things. So we want to encourage them to talk about it. Well, I can see that you're feeling this way. Why are you feeling that way? Tell me what's going on. What are you upset about? Really get the patient to discuss what the challenge is for them. Explore alternatives when given these challenges, and then develop spiritual beliefs that meet the need for meaning and purpose, care and relatedness, and forgiveness, according, of course, to what's important to the patient. When we are preparing the room for a spiritual counselor to come or to visit with the patient. We want to make sure that the room is kind of how like they would have it at home. We want to make sure that it's open, that it's inviting as best as we can. So make sure that it's orderly. If there's unnecessary equipment in there that we don't need, we can take it out of the room until they're done with their, with their counselor. We want to make sure that the spiritual counselor has a place to sit near the patient's bed so they can really be present with the patient and interact with them. Clear the top of the bedside table and cover with a clean white cloth or sacraments, 4 sacraments if that's what they're going to have. And then we can draw the bed curtains if the patient cannot be moved to a private setting, if there's a room where 2 or more patients are in the same room. And then lastly, we are going to want to evaluate those expected outcomes. So we want to be able to identify some spiritual beliefs that give meaning and purpose to life. We want the patient to be able to tell you those. What are some things that are important to them that give them meaning? What drives them? What gives them purpose for life? We want them to be able to move towards healthy acceptance of the current situation. So how will we know if they're moving in a healthy way towards accepting the situation? Well, if they first get diagnosed with diabetes, the first day they might be like, that's it. I just can't deal with this anymore. It's one thing after another. I'm never going to be able to do this. I'm never going to be able to live with diabetes. I'm not going to be able to change my diet. I might as well just die. These are things that you actually hear from patients sometimes because they get very overwhelmed. After a day or two, you might hear them say, I know that if I just make a couple changes to my diet and I start exercising, I can live with this. I can manage this disease and maybe one day I won't even have it. So that is a way that you can gauge that they are moving towards a healthy acceptance of the current situation. You expect to hear that negative at first, but then it should progress into some positive. That time frame in between is different for each person. So we can't say, well, you should be here by now. It's like stages of grief. It's different for each person. We want to develop mutually caring relationships. We want them to know that as their nurse, we care about them. We care about their well-being. You're showing them that you care by being present with them, just by being silent sometimes, listening to them, and by identifying these spiritual factors that are important to them. We want to be able to reconcile interpersonal differences that cause anguish for the patient. We want to want the patient to verbalize satisfaction with the relationship of God, if they have a God and they believe in a God. We want them to express peaceful acceptance of limitations and even failing. And we want the patient to express ability to forgive others, and then to be able to live in the present. And then lastly, we want to be able to demonstrate interior state of joy, freedom from anxiety, and guilt. That takes a lot for most people. I feel like that's a work in progress, but it is an outcome that we would like to see. All right, so that was spirituality and culture. Next, we are going to talk about ethics and health law. All right. So for legal and ethical aspects of nursing, you are going to have information regarding this in your Taylor book, chapter 6 and 7, and then your Timby book, chapter 5. So there is a video that I want you guys to watch if I can get it to work. Hold on, let's see if I can get it. My internet's being slow. I'm not sure if it's going to load or not.
We think that nursing is just about the bedside. For most of us, the bedside is the beginning, but it is just the beginning. And for me, the bedside experience that I had has informed everything else that I've done. So in my day-to-day life, I teach nurses about ethical issues in nursing practice. And I work with them to see how important ethics is as a foundation for our profession. It was in the 80s when we had a series of baby doe cases. The government instituted what was called infant care review committees. And it was really the precursor of what we know today to be ethics committees. And it was the first attempt to bring together an interprofessional group of clinicians to review cases where there were ethical questions about what ought to be done. Because I was in my role there as a clinical nurse specialist, I was asked to represent nursing in that forum. That was really the beginning of my dedicated focus in ethics. And I've been doing it ever since. My advice to nursing students is be who you really are and go for it. Always keep your passion alive. I'm Dr. Cinda Rushton, and I am a nurse. I love being a nurse. We got this.
All right. All right, so objectives for ethics and legal aspects of nursing is we want to be able to describe nursing practice that is consistent with the code of ethics for nursing. So nursing actually has their own code of ethics. We want to identify the 4 functions of institutional ethics committees. We're going to describe 4 sources of laws. We're going to identify the purpose of credentialing, such as license and certification of nursing. We're going to identify grounds for suspending or revoking a license. We're going to differentiate between intentional torts and unintentional torts. We're going to explain the purpose of incident reports in the healthcare setting, and then we are going to describe laws that affect our nursing practice. So, being a nurse where we have to make critical decisions every day about the best way to treat a disease can cause us to sometimes think, how am I going to do this? Should I do this or should I do that? What is the right way to do things? Is this the wrong way? Am I doing what's best for the patient? It can be hard for the patients. It can be hard for the family members. It can, especially for vulnerable population, it can be hard for doctors. It's hard for everyone. So as nurses, we need to just understand the importance and the impact that providing ethically sound care to our patients, what that will provide to them. Okay, so one nurse may believe that abortion is ethically justified in situations that result in the best consequences for the woman, the child, and society. Other nurses may believe that abortion is wrong based on a rule that an innocent life should never be taken. So this is a good example of an ethical conflict. The way that each person believes is completely correct because that is what they believe and that's what's important to them. I might not believe that an innocent life should never be taken, but that doesn't mean that it's wrong. It's my personal belief and we have to respect each person's belief. But then we also have to be able to as healthcare providers, come to a common ground and meet the needs of the patients. So these are the things that we're going to talk about. We're going to talk about some ethical theories. So there are ethical frameworks or ethical theories that are designed to help explain how we should live and why. So we have the utilitarian theory. So this is the basis that the rightness or wrongness of an action depends on the consequence of the action. With this theory, they make decisions that benefit the greatest number and harm the fewest amount of people. Utilitarianism is a theory of normative obligation, which answers questions by saying, do that which produces the most amount of good, okay? Then we have the deontologic theory. That is that an action is right or wrong independent of its consequences. Consequence and duty are equally important. An example of this is that nurses have a professional duty to clients to maintain life regardless of the outcome. So the example that we just gave on the slide before regarding abortion, one nurse might believe that abortion is ethically justified in a situation that results in the best consequence for the woman, the child, and the society. That would be a utilitarian theory. The other nurse that believed that abortion is wrong, no matter what, because it's an innocent life, that's the deontologic theory, okay? So those are examples. You guys need to know these theories. You're going to see them again. All right. So we have bioethics. So the principle-based approach to ethics combines elements of both that utilitarian that we talked about and that deontological theory, and it offers special action guides for our practice. So this looks at a 4-key principle. The four principles are autonomy, non-maleficence, beneficence, and justice. There are some nurses that believe that fidelity, veracity, accountability, privacy, and confidentiality are also included in ethics, and they are, but when we talk about this specific principle, we're just looking at these 4 key principles. This principle offers general guidelines to help us decide which actions we should take. And it's not always as simple as this sounds. It's very, very difficult to still make these decisions. So when ethical dilemmas arise, we try to adhere to these basic ethical principles that will ultimately result in a course of actions. So we have to be sensitive to the fact that the patients, the family members, and all those involved in caregiving, so the doctors, the physical therapists, the nurses, we all may identify benefits and harms differently. So when we talk about justice, so justice is give each his or her due. This requires us as nurses to act fairly. We always want to seek to distribute the benefits. So what is the benefits of this treatment? What is the risk of this patient having this treatment? So these are the benefits, these are the risks, and what are the costs of not nursing care justly? So that is justice. Fidelity is keeping promises, being faithful to the promise that you made to the public to be competent to the patient that entrusted you to care for them. So keep your promises, okay? I'm not going to talk about autonomy, non-maleficence, and beneficence here. We're going to go into these next couple slides because they're pretty important. I want to talk about them individually. So autonomy, this is respecting the rights of patients or their surrogates to be able to make healthcare decisions. So this is providing information and support to family members and patients to help them make the decision that is the best for them. This includes us collaborating with other members of healthcare teams to advocate for the patient. So we know if Mrs. Jones just had a fall at home and she had a broken hip, we know she's going to go back home. She doesn't have any family member here. They all live out of state. She has 13 steps to get into her house and another 10 in between her main floor and her second floor. We know that she's probably not going to be able to navigate steps with a broken hip. And she only has one bathroom and it's on the second floor. So we need to advocate for our patient, right? We would need to encourage them to have autonomy and recognize what needs they have so that we can help them make the right decisions. So talking to her about her home status, tell me a little bit more about your house. Who do you have to help you? What's important to you? Do you think you're going to be able to do this? We have to encourage our patients sometimes to have autonomy in their care. This gives an individual the freedom to be able to make choices about issues that concern their life and their medical issues. So we know that Jehovah's Witnesses, if a physician orders 2 units of packed red blood cells because they have a low blood level, the nurse is responsible for informing the doctor that this would be unethical to go against the patient's preference. Maybe the patient is incoherent at the present time because their blood's so low, something happened, they can't speak for themselves. This would be the nurse's job, okay, to then come in and have respect for the patient's autonomy and make sure that we are advocating for them in all aspects of their care. So then we have non-malfeasance. So this is going to be, you're going to have to know about all 3 of these. You're going to see these on your exam. So this is related to beneficence, but a little bit different. So we have, as nurses, a duty to do no harm to our patients or to minimize harm in pursuing a greater good. The nurse is to act in such a manner to avoid doing harm to patients. The principle is based on the Hippocratic Oath that we take as nurses, to first do no harm. The healthcare provider is to look at the risks and the benefits to treatment, and their commitment is to provide the least harmful interventions. Okay? Then when we talk beneficence, which is closely related to non-malfeasance, it is being able to take positive action to help others while always looking out for the best interest of the patient. So we have a duty to do good and to maximize the good that we do. So we want to do things that benefit the patient and balance those benefits against the risks and the harms that come with certain treatments. This is doing or promoting good. The 3 major concepts of beneficence are to promote good, to prevent harm, and to remove evil or harm. So our primary commitment from the nurse is to the health, the welfare, and the safety of the patient. You commit yourself to actively promoting the patient's benefit, so their health and well-being. And we need to be sensitive to the fact that patients, their family members, and professional caregivers may identify benefits and harms differently. We all may see things differently. One benefit to one could be a burden to another. So we all think differently. And then we have informed consent. So every person is granted their freedom from bodily contact by another person unless consent is given. In most states, you have to be 18 years old to be able to legally provide medical consent. In all healthcare facilities, Informed and voluntary consent is going to be needed for you to get admitted to the hospital. It's needed for specific diagnostic or treatment procedures. It's required for any experimental treatment or procedures. The consent must be written. It must be designated for the procedure that's to be performed. So it can't just be, I give GBMC hospital the permission to do anything that they need to do for me while I'm here. It has to be very specific. So it has to be, if they're getting a blood transfusion, it has to be a consent form for a blood transfusion. If they're having an EGD, it has to be a consent form for an EGD. So it has to be written and designated for the procedure being performed. And it has to be signed by the patient or a person who's legally responsible for that patient. Signed consents are not needed in an emergency if there is an immediate threat to life or health. If experts would agree that it's an emergency, and if the patient is unable to consent and a legally unauthorized person cannot be reached, then the healthcare provider acts and does what he needs to do in order to save the patient. Who's responsible for obtaining this informed consent? So this is going to be the responsibility of whoever is performing the diagnostic procedure or the treatment procedure. Or even we have to get consent for research studies. So whoever's running the research study. So your role as the nurse is to confirm that a signed consent form is present in the patient's chart, or if it's been scanned into the electronic chart. And it is also your responsibility to answer any patient questions about the consent. It is not your job to fill out the consent form. I'm not going to say that I haven't done it before, because in emergency situations I have, or if the doctor's been in an emergency situation, I've had to do that, and it's okay, but it is not part of our scope of practice that we do, unless you're obtaining consent for a nurse prescribed or a nurse initiated intervention. As the nurse, you sign the consent form as a witness. So usually the doctor will go in and say, Mrs. Jones, we're going to give you 2 units of packed red blood cells. This is the benefit of the packed red blood cells. This is what could happen if you don't get them. And this is a side effect of getting a blood transfusion. You may have X, Y, and Z. So you're there as the witness. You hear the doctor explain the procedure. The doctor has the patient agree to it or disagree. If he agrees, the patient will sign the informed consent. Then the doctor will sign and date it. And then you will sign and date it as a witness. That you recognize that, yes, the patient is acknowledging that they want to have this procedure. Okay, so that is the role of the nurse with the consent form. Confidentiality. So confidentiality is the non-disclosure of private or secret information about another person. So the nurse is only to share that information that is necessary to provide patient care. This is the only ethical principle that, if it is breached, could result in criminal conviction. So you have to be confidential when you are taking care of your patients. When we talk about ethical conduct, so nurses are committed to delivering high quality care based on our practice and our professional standards of ethical conduct, as well as all the professional values that we hold. We should, if we are aligning ourselves with ethical conduct, we should cultivate the virtues of nursing. What does nursing encompass? We need to understand ethical theories that dictate and justify professional conduct. We need to be familiar with the code of ethics for nurses and standards for professional nursing conduct. A code of ethics is a set of principles that reflects the primary goals, the values, and the obligations of our profession. It's just designed for the profession of nursing. Virtues, we said we have to cultivate the virtues of nursing. So virtues are human excellences. They're cultivated dispositions of our character and our conduct that motivate and enable us to be good human beings. Clinical virtues enable nurses to provide good care to patients. There's really not like an official list. You can't just Google clinical virtues that's going to come up. But some of the ones that are named when we talk about them are competence. So being competent in the care that you provide. How do you become a competent nurse? Through experience. We don't expect any of you to be competent nurses when you graduate because you don't have experience. But as time goes on, you will learn things and you will remember how to do things and you will be competent. Another virtue is compassionate caring. Care about your patients. Treat your patients the way that you would want your loved one to be treated. When you're thinking about making a decision about your patient, think about if you were making that decision about your family member, or if another nurse was caring for your family member, what decision would you make? What decision would you want them to make for your family member? And that's the decision that you should make. Subordination of self-interest to patient interest. So we have to make sure that we are not thinking about what benefits us and what is important to us. It's what benefits our patients. We should be trustworthy and honest. We should be conscientious. We should pay attention to every detail, what the patient needs, changing their linens, pay attention to those little things. How do they like their ice water? Do they like it with no ice? Do they like it with just a quarter of a cup? We want to be conscientious about little things that mean a lot to people. We should be intelligent. So we should always keep learning, always keep going to school. That's contributing to the nursing profession. Don't just stop with your LPN. Go on to be an RN, then get your BSN, then get your master's, maybe become a nurse practitioner. Always contribute, give back to nursing. We should practice humility and we should have courage. It takes a lot of courage to take care of patients every day. It's not an easy thing to do. It makes us face things that we're not always comfortable with. And then the last virtue that we should have as nurses is integrity. So purpose, according to the ANA, the American Nurses Association, people who become nurses are expected not only to adhere to the moral norms of our profession, but also to embrace them as part of what it means to be a nurse. So the ethical tradition of nursing is self-reflective. We have talked about that since day one, that we have to self-reflect on our practice. We have to look at our biases. We have to look at things that are important to us. We have to reflect on our practice and what we're doing. The tradition of nursing is also enduring and it is distinctive. A code of ethics, which we said a couple slides back, is a set of principles that reflects the primary goals, the values, and the obligations of our profession. The ANA Code of Ethics for Nurses serves the following purposes. It is a succinct statement of the ethical obligation and duties of every person who enters the nursing profession. It is the profession's non-negotiable ethical standards. And it is an expression of nursing's own understanding of its commitment to society. And you can read more about this on page 106 in box 6.1 in your book. So ethical problems. So we can have an ethical dilemma or an ethical distress. So ethical experience comes in a lot of different ways to nurses. Two of the most common ethical issues that we deal with are these two that we just talked about, the ethical dilemma or the ethical distress. In an ethical dilemma, that we talked about earlier, there could be two or more clear moral principles that apply, but support mutually inconsistent courses of action. So one believes this, one believes that, the beliefs don't align and they can't agree on what should happen. Moral distress occurs when you know the right thing to do, but either personal or institutional factors make it difficult to follow the course of action. So there are a couple steps that we have to look at when we are trying to resolve an ethical dilemma. First of all, we have to recognize that there is a dilemma. We have to recognize the problem and then describe the situation, what's happening, and the contextual factors that caused this ethical issue to rise, to start to begin with. And then we have to review all the pertinent information. So this involves all the people who are involved in this. So if it's the patient, family members, doctors, nurses, physical therapists, speech therapists, whoever is involved in this situation, we need to talk with them and get their views and their interests. Solving ethical dilemmas usually takes a while, a couple weeks usually, because there's a lot involved. We want to know the patient's overall nursing, medical, and social situations. We need to look at all that information is pertinent. And then we need to know any relevant legal issues and any administrative or staff considerations. Once we gather all that pertinent information, then we examine and determine personal values that are related to the issue. We verbalize the problem. It could be a different problem depending on what person thinks what. So to one person, because of their beliefs, it might not be a problem. To me, it might be a problem because of the way I believe. So we verbalize the problem or the problems, and then we formulate the best possible course of action. We negotiate an outcome and we move towards responsible collaboration through communicating and understanding. And then we evaluate the action and outcome. All right. So tell whether the following statement is true or false. A nurse who is dedicated to providing culturally competent care to her patients finds herself without the resources to communicate with a patient who speaks a different language. This problem may result in an ethical dilemma for the nurse. True or false?
True.
True. Absolutely right. If you don't have, as the nurse, what you need to be able to educate your patient and talk to your patient, there can definitely be some type of ethical problem that's going to arise in the future because there's going to be a lack of communication. Okay. All right. So this is just a little guide to help us be able to rise above moral distress. This was designed by the American Association of Critical Care Nurses. They developed this helpful model. So we do, in the critical care setting, in the ICU settings, this is where they see a lot of ethical dilemmas because, you know, things like patients will come in and they'll come in unconscious, but maybe they have an advance directive that says, you know, if I'm going to be in a vegetative state, I don't want to have X, Y, and Z done. Well, even though they have that piece of paper, it doesn't happen like that sometimes when they go into the hospital. Family members come in and they say, well, I'm the power of attorney and I make decisions for him and I want you to do life support and I want you to give a feeding tube and I want you to do everything you can for him. Even though there's been tests that show there's no brain activity and stuff like that. So then you might have the sister who says, this isn't what dad would want. But then you have the brother who's saying, well, I'm in charge. I have the power of attorney. This is what we're going to do. This is an example of an ethical dilemma. So the family members don't agree. Nobody's listening to the facts. So then it has to go to the hands of someone else who's not related to this loved one. It's never an easy thing to have strangers make decisions about your loved ones, but sometimes this happens. So I'm going to let you read over this later when you're studying. And then the nursing process in solving ethical issues. So in order for the nurse to be confident in ethical decision making, we can use these steps to help guide our ethical decisions. So step one, again, assess the situation, gather that data, recognize and then describe the situation and any factors that cause this ethical problem. Diagnose the ethical problem, plan, So we're going to identify alternatives and weigh those alternatives, short-term consequences, long-term consequences for each person. Use ethical reasoning to decide on a course of action that you can justify ethically. Identify your personal and professional moral positions and values of those of other people that are involved. You're going to make sure you're applying those pertinent ethical theories and principles that we talked about earlier. Apply any code of conduct and ethics, any professional position statements or guides, or any institutional policies. Consider consult.
David, can you change the slide, please?
Oh, I'm sorry. Yes, thank you. Decide on a course of action that you are best able to support. Then step 4, you're going to be implementing your decision. So whatever your decision is, you're going to implement that decision, begin to compare the outcome of your action with what you considered and hoped for. What was your goal? And then lastly, you are going to evaluate your decision. So what have you learned from this process that will help you in the future? How can you improve your reasoning and your decision-making in the future? And in what ways does the institution that you work for, what does their culture need to change in order to prevent similar conflicts in the future? So this is a list of some ethical problems that have been seen in the clinical settings. So we have paternalism. This occurs when a nurse acts for a patient without consent to secure good or to prevent harm. Deception occurs when a nurse deceives a person for a perceived benefit. So when the patient, if maybe is you're a nursing student or a nurse and the patient says, is this the first time you've ever given a shot? Oh no, I've done it a million times. Not being honest because you don't want the patient to feel nervous or because you don't want the patient to say, well, I don't want you to do it. Patient confidentiality is questioned when patient confidence may lead to harm. Allocation of scarce nursing resources and advocacy in a market-driven environment involves patient harm due to inadequate staffing and finances. So this is something that you will always see. Having the resources that you need is always an issue, and then being inadequately staffed is something that we deal with all the time in nursing. Beginning of life issues, so abortion, end of life issues, dying with dignity, short staffing and whistleblowing, unprofessional, incompetent, unethical, or illegal nursing practice. This is something that you're definitely going to see because not every nurse goes into nursing because they love people and they have ethical values and they want to do the right thing. For some people, it's just to make money. And then you see these unprofessional traits come out. And we have unprofessional, incompetent, unethical, or illegal physician practice, conflicts concerning new technology like infertility, and then valid consent or refusing consent. So still doing something after the patient says, no, I don't want that done. So we talked about sometimes we may have to go in front of this ethics committee. So this ethics committee is made up of attorneys, nurses, physicians, risk management, social workers. It can be clergy members from a local church, community members. It's a variety of people. Their responsibility is to review our institutional policies. They're going to be able to provide education on ethical issues or concerns. They're going to consult who they need to consult, review cases, and determine ethical decisions as a result. What decision needs to be made for the patient? All right, so this is a standard rule of conduct that is established and enforced by the government, and this was designed to protect the rights of the public. This is a law, okay? They are standard or rules of conduct established by government and enforced by government. An example of the elder law is a hotline, which is a phone number that anyone over the age of 60 can call to get free legal advice on any number of legal issues. They give free legal services for the elderly. So some issues that it helps with is power of attorney, helping them determine their wills, simple wills, that is, living wills. So who's going to make decisions for them when they can no longer make decisions for themselves. And then it says sometimes they can represent elderly in divorces and landlord-tenant cases. So this is the elder law hotline. Now we're going to talk a little bit about law terminology. So litigation. Litigation is a process of bringing about and trying a lawsuit. The plaintiff in litigation is the person who is bringing the suit. This is the person that has the problem. And then the defendant is the person being accused of a crime. And they are presumed innocent until proven guilty. So we have 4 sources of law that exist on both the federal and the state level. So we have constitutions, statutory law, administrative law, and common law. So when we talk about constitutions, these are federal and state constitutions that indicate how our federal and our state government are created. So they give authority and state the principles and provisions to be able to establish certain laws. There's only a few laws. They're called constitutional laws, and constitutions serve as a guide to legislative bodies. And we have statutory law. So a legislative body which enacts statutory law. Statutory laws must be in keeping with both federal constitution and the state constitution. Nurse practice acts that determine how we act are an example of a statutory law. You guys need to know that. Administrative law. So this is executive officers such as the President of the United States, state governors, mayors. They administer facilities that are responsible for law enforcement. So these facilities have the power to make administrative rules and regulations with that enacted law. They act as laws that are enforceable. Boards of nursing are considered administrative facilities at the state level. The rules and regulations that they adopt are considered administrative laws. And then common law. So common law is a body of unwritten laws based on legal precedences established by the courts. Common law will influence the decision-making process in unusual cases where the outcome cannot be based on existing statutes or written rules of law. So those are the 4 sources of law. Now we're going to talk about the types of law. So we have public law, private law, and criminal law. So a body of law, also known as a common law, has evolved from judiciary decisions. Most law involving malpractice, which we see as healthcare providers, is considered common law. Public law is which the government is involved in directly. So it will regulate relationships between people and the government. Private law, which you also may hear called civil law, they're used interchangeably, regulates relationships among people. So civil law includes laws that relate to contracts, ownership of property, the practice of nursing, medicine, pharmacy, and dentistry. And we have criminal law, which is a type of public law, which concerns state and federal criminal statutes, which define criminal actions such as murder, manslaughter, criminal negligence, theft, and illegal possession of drugs. All right, so a crime is a wrong against a person or that person's property as well as the public. That's the definition of a crime. A misdemeanor is punishable by, is a type of crime that is punishable by fines, money, or less than 1 year of imprisonment. A felony, much more serious than a misdemeanor, is punishable by imprisonment more than a year. Then we have a tort, which is a wrong that is committed by one person against another person or that person's property. And it can be tried in a civil court. An act that is a tort may also be considered a crime. Then we have two types of torts. You can have an intentional tort or an unintentional tort. All right, so intentional torts. So I don't know why you guys are missing this. Hold on a second, let me copy this. Okay, so intentional torts. Intentional torts are assault and battery, defamation of character, invasion of privacy, false imprisonment, and fraud. So assault and battery, that is a threat or an attempt to make bodily contact with another person without that person's consent. Battery is an assault that is carried out, okay, and includes willful, angry, or violent or negligent touching of another person's body, their clothes, or anything attached to or held by that person. So forcibly removing a patient's clothing, administering an injection after the patient has refused it, pushing a patient into a chair. These are all examples of battery. So most people don't even think of that in terms of nursing. But when we do something to a patient that they have not given us informed consent to do or permission to do, it is considered battery. Threatening to do any of these actions, if the patient does not cooperate, is considered assault. So if you say, Mrs. Jones, if you get out of bed one more time, I'm going to give you the biggest needle ever right in your butt, okay? That's assault. You cannot threaten to do things like that to patients. Battery is if you go ahead and give her that needle without her permission. Defamation. So defamation of character is an intentional tort in which one party will make a derogative comment or a remark about another one that diminishes the other person's reputation. We have invasion of privacy. So the US Supreme Court has actually interpreted the right against invasion of privacy as a constitutional right. So the Fourth Amendment gives citizens the right of privacy and the right to be left alone. State courts have also strongly protected a patient's right to have information kept confidential. Then we have false imprisonment. So this is unjustified retention or prevention of the movement of another person without proper consent. That will constitute false imprisonment. For example, only a reasonable amount of restraint should be used in circumstances that warrant it. The indiscriminate and thoughtful use of restraints on a patient can constitute false imprisonment. So we need to make sure that we are using restraints on our patients, that we are using the least restrictive device for the least amount of time. We can't just say, well, Mrs. Jones keeps hopping out of bed, so she's going in restraints until the nurse comes in tomorrow at 7 because I can't keep watching her anymore. My assignment's too busy. That's considered false imprisonment. Then we have fraud. So fraud is willful and purposeful misrepresentation that could cause or has caused loss or harm to a person or property. And then we have unintentional torts. These unintentional torts are usually based around negligence, even though they can be considered accidental and they're still punishable under civil law, okay? So unintentional torts are based around negligence. They can be accidental, which means you didn't do it on purpose, but it's still punishable, okay, under civil law, whether you meant to do it or not. This includes car accidents. This includes patients slipping and falling in the hospital, medical malpractice, something that physicians did or nurses did that hurt a patient, dog bites, workplace accidents, things like that. Negligence and malpractice. So negligence is defined as performing an act that a reasonably prudent person under similar circumstances would not do, or conversely failing to perform an act that a reasonably prudent person under similar circumstances would do. The act of negligence may be an act of omission or commission. Malpractice is the term generally used to describe negligence by professional people, such as nurses and doctors. And then we have elements of liability. So this legal practice or principle rather applies to individuals or entities, regardless of intent, and it imposes liability without the need of direct fault. The most common example of strict liabilities are product defect laws. And there's more about this in your book if you guys want to read that. So a client arrives in the emergency room and is staggering and confused. When the patient becomes verbally abusive, the nurse threatens to place the client in restraints. Which of the following can the client legally charge the nurse as a result of nursing action? A, assault, B, battery, C, negligence, or D, invasion of privacy?
A.
A, you got it. You are threatening to put the patient in restraints. If you would have actually put her in restraints, then what would it have been?
B.
Battery.
B, battery, correct. All right, so we do have professional and legal regulation of our nursing practice. So, you know, we have a lot of safeguards that were implemented to help protect nurses from having any type of legal action. There are many laws that govern our practice to protect us and to keep our patients from harm. So our State Nursing Practice Act is the most important law that affects our nursing practice. You guys need to know that. That's why it's in bold. The State Nursing Practice Act is the most important law that affects our nursing practice. Each state has their own Nurse Practice Act. They're not all the same. That act that they decide upon protects the public by defining the legal scope of nursing practice. It tells us what we can do and what we can't do. You are responsible for obtaining a copy of your Nurse Practice Act from the State Board of Nursing, studying it and knowing it. You can always visit the National Council of State Board of Nursing, NCSBN. For more information, talks all about nursing acts and how to contact your state board. Each nurse is expected to care for patients within their defined practice limits. When you practice beyond those limits, performing things that are not in your scope of practice, you make yourself vulnerable to charges of violating the state's Nurse Practice Act. So as the nurse, if your patient was decompensating and their oxygen level was in the 80s and you called a rapid response, you're going to put a non-rebreather on that patient. You're going to sit them up. You might put in an order for a verbal order for a chest x-ray for your patient because the doctor told you to. These are all things that you would do as the nurse. If your patient further decompensated and they needed to be intubated, you would not intubate them. Okay, that is not in your scope of practice. That is in the physician's scope of practice or respiratory therapy. So you need to be careful that you are only doing things that are in your scope of practice, even if you know how to do them. You still can't do them. We talk about standards. So standards are developed and implemented by the nursing profession themselves. They're not mandatory, but we use these standards as guidance for our practice. Professional nursing organizations that are designed, one of their jobs is to constantly reassess the standards and qualifications of nurses. They are guided by their own assessment of the needs in society by nursing and also what the public expects from nurses. Then we have credentialing. So nursing has taken several steps to ensure the competence of healthcare providers, including credentialing. So credentialing refers to the way in which professionals' competence is ensured and maintained. So this is a way that our hospitals know that we are competent in the care that we can provide. We're credentialed. We have a license. We've taken these courses. There are 3 processes that we use for credentialing in nursing. The first is accreditation. So accreditation is the process by which an educational program is evaluated and recognized as having met certain standards. So that would be the LPN program. So we are accredited. We know what LPNs need to be taught. We're constantly evaluated, and they make sure that we are meeting certain standards. The second is licensure. This is the process by which a state determines that the students that we taught now meet a certain minimum requirement to practice in that profession. And once you take that NCLEX and you pass, the state recognizes that you've met those requirements, and they give you a license so that you can practice as an LPN. And then the third is certification. So this is the process by which a person who has met certain criteria established by a non-governmental association is granted recognition in a specified practice area. So when I was working on the oncology floor, I was certified through the oncology society to give chemo. So that was considered a certification. So the Maryland Board of Nursing is the state board of nursing for us. They're mandated to regulate the practice of licensed and unlicensed professionals. The mission of the Board of Nursing is to advance safe, quality care in Maryland through licensure, certification, education, and accountability for public protection. And we talked about those nurse practice acts. So nurse practice acts are laws that define and regulate the practice of nursing in the United States. Nurse practice acts list the violations that can result in disciplinary action against a nurse, and also intend to prevent untrained or unlicensed people from practicing nursing. You should, as an LPN or a nurse, know and understand your state regulations. It is your responsibility. So we do have different laws that affect nursing practice. So we have occupational safety and health laws. So the Occupational Safety and Health Act of 1970 was designed back then to set legal standards in the US to ensure safe and healthy working conditions for all people. It's also called, some people call it OSHA for short. The act is intended to reduce work-related injuries and illnesses that affect healthcare facilities for doctors, nurses, physical therapists, dietary, housekeeping, everyone that works in the hospital. So there are some examples here that I'll give you of situations that could violate standards if care is not taken because they pose a possible threat to our safety. So the use of certain electrical equipment, it has to be checked. It has to be made sure that it's working appropriately. It has to have numbers and labels on it of when it's checked and when it's regulated to be rechecked again. The use of isolation techniques for patients with infectious disease and the management of contaminated equipment and supplies. So do we have negative pressure rooms for patients who are on airborne precautions? When we have patients on airborne precautions and we take a vital sign machine in there, when we come out, are we using the purple wipes to wipe everything down in between each patient? Are we wearing our masks? Are we wearing our gowns? The use of radiation, so using infrared or ultraviolet radiation or sound waves or laser beams, are we using these and taking the proper precautions for the patients and ourselves? And then use of chemicals. So when we're using chemicals that are toxic or flammable, so certain Medications like chemotherapy, are we handling them with chemotherapy gloves? Are we wearing gowns? Are we certified to give them? So these are the things that OSHA looks at. Then we have the National Practitioner Data Bank. So this was developed by the Healthcare Quality Improvement Act. And this act encourages the identification and discipline of healthcare providers who engage in unprofessional conduct, and it works to restrict their ability to move from state to state without disclosure of their previous performance. So if you heard about that doctor a couple years back who was a gynecologist, and they found in his office, all these pictures of these naked women, and he left and went to another state. Well, they quickly found out what he did, and they wouldn't grant him a license because they have this national practitioner database. Reporting obligations. So we, working with nurses and patients have kind of like a unique relationship with their interactions. So we frequently, as nurses, have knowledge about a situation that requires to be reported to the state. So the things I'm thinking about are child abuse, if a patient's been raped, or if a patient has a communicable disease, or elder abuse, things like that. We need to know what those laws are, what needs to be reported, and what local area we have to report them to. When we think about controlled substances, so the United States has special laws that that govern the distribution and use of controlled substances, especially those with abuse potential. We talked about this in pharmacology during week 1, I think. There's specific drug laws about abuse, and violations of this are considered criminal acts. So as a responsibility of a nurse, you are responsible for making sure that you control your substances and you store them in specially locked compartments. You don't just leave them out on your counter or your computer on wheels. When you walk away from them, you don't have Dilaudid or morphine sitting out that could get into the wrong hands. And then you are responsible for using that medication for your patient, and then wasting any medicine that you don't use, and then not using that medicine for yourself for abuse. And then discrimination and sexual harassment. This protects employees from any kind of discrimination based on their race, their color, their religion, their sex, their national origin. The Health Insurance Portability and Accountability Act, I think everybody knows what this is, HIPAA. So this protects against discrimination against people in certain areas such as employment, housing, public accommodations, education, transportation. It also protects patients and all their information. Then we have legal issues related to death and dying. So these are our advanced directive papers where patients can designate a certain person, whether it be a friend or a family member, that can make decisions for them if they can't make decisions for themselves. Then we have do not resuscitate orders. So this is where the patient says, I don't want to be resuscitated if this is how you find me, or I want you to try and do CPR, but I don't want to be intubated. In some states, assisted suicide is legal. It is not legal here. I'm not going to spend a lot of time on that. Organ donation. So is your patient an organ donor? Autopsies, things like that. So advanced directives. So an advanced directive is where you can determine in advance, before something happens, any information regarding life-sustaining treatment and medical care. So there's a couple different types. So there are living wills. So living wills provide specific instructions about the kinds of health care that should be provided in particular situations. A durable power of attorney for health care will appoint an agent that the person trusts to make decisions in the event of subsequent incapacity. So you have a living will right now, you're completely healthy, you know what you want. If something happens to you and you go into a coma and they determine that there's no brain activity or that you will not have a useful good quality of life, then you do not want to be intubated. You do not want to have a feeding tube. You don't want to have artificial nutrition. That you already know that these are not the things you want. So you can put this on a piece of paper. That durable power of attorney is someone that's going to make a decision for you if you're incapacitated. And that person should know your wishes and what your living will says so that they can honor your wishes. Those do not resuscitate orders, we talked about that. That's a written medical order for the end of life instructions. It's a physician's order and it is part of the advance directive. So this is where you can go in and say, well, I want you to do CPR, but I don't want to be intubated. Or I do want to do CPR, I do want to be intubated, but I don't want to have tube feedings. I don't want to be fed through a tube. Okay. So if you have, I want you guys to understand who is responsible for what. So if you have a patient who comes into the hospital, an older woman, maybe she has a UTI. She normally lives on her own and is completely coherent, but she has a UTI, so she's a little confused now. She's fatigued, she's out of it. She has an advance directive that identifies that her daughter is her legal healthcare agent or her durable power of attorney. If we decide to send this patient to MRI for contrast for a head injury, because maybe she was confused and fell, we need to have consent, right? We talked about informed consent. We need to be, the patient has to consent to having the MRI. So if the patient is too groggy, it's not really a good idea to have that patient sign that consent. So then you would want to look on that form, that advance directive, and find out who that durable power of attorney is, and then have that person give the consent, because that is who the patient identified as someone that knows their health interest and can make good decisions for them. So sometimes there could be a reason where you would have your license revoked or suspended. So if you have a drug addiction or alcohol abuse, you could lose your license. Fraud, any kind of deceptive practice, any kind of criminal acts, stealing drugs, selling them on the street, previous disciplinary actions, and then say they give, so sometimes when I talk about drug or alcohol abuse, because we're living in a time where we see this all the time, it happens a lot in healthcare professionals. So sometimes if a nurse is caught stealing drugs and they have a problem and they admit it to the healthcare facility might say, okay, I want you to go through 3 months of treatment. If you go through 3 months of treatment, we'll give you your job back and we won't turn you into the board. Sometimes they might say, we're going to let you go and we're going to turn you into the board. So then the board may say, well, we're suspending your license for a year. You need to do X, Y, and Z. And then in a year, we'll reevaluate your circumstances and you may get your job back. And I've seen it where nurses a year later get their job back. Then if they do it again, so previous disciplinary action, well, then it could be revoked forever because you already had your one chance, you did it again. We're not going to give you a second chance. So any kind of gross or ordinary negligence that maybe resulted in a patient dying, and then physical or mental impairments, including age. So due cause of revoking a license. So just upon the theory that everybody charged with a crime is innocent until proven guilty, this is kind of the same way. So you have to have a notice of an investigation. You also have to have a fair and impartial hearing. All sides need to be heard, and then you need to have a proper decision based on substantial evidence, not just hearsay. So then, of course, there's always the issue of malpractice in healthcare setting, and nurses are no different. They can be sued just like doctors. So categories of malpractice claims that we see are when healthcare providers fail to follow standards of care. So standards of care are what your profession has decided working within your scope of practice, or what the hospital has decided how you should treat people and treat certain health conditions. Then we have failure to use equipment in a responsible manner, failure to assess and monitor a patient, failure to communicate with family members, with other healthcare professionals that cause something terrible to happen, failure to document. We said this before when we talked about this back in the first couple weeks of this class, that if you do not document it, even if you did it, it was never done. So you have got to document throughout the day all pertinent information. And then failure to act as a patient advocate. If you don't advocate for your patient and you know what's important to them and something bad happens to them, you can be sued. That is your job as a nurse, to be a patient advocate. So again, this is just the same thing. We just talked about all these. How can we minimize malpractice risks so we can avoid offering any legal advice to patients, family members that we don't know ever, even if we think we know something about it? Don't offer any legal advice to patients. Seek assistance if you don't know. This is the only profession where it is always acceptable to have like 25 years of experience and still ask questions about things you don't know. It is always acceptable to seek assistance. You're never going to know everything in nursing. Always ask somebody else. You can be competent in your practice. Like I said, you're not going to have competency when you first graduate, but over time, as you get experience, you will become competent. If you're not competent at something, if you're doing a new, maybe you've never given blood to a person and you've been a nurse for 7 months. So the first time you go to give blood, you're going to pull that policy, right? You're going to use your resources that are going to help you be competent with this task. You're going to go grab another nurse that you know who has given blood and say, look, I've never done this before. I don't feel comfortable doing it by myself. I need you to be with me the first, second, third, or fourth time that you give it until you feel competent. You can follow your hospital's policies and procedures. Every hospital has a tab on their info web that talks about all the hospital policies and the procedures. Just the other day, I had to do something I've never done before. I had to give a patient blood in a blood warmer. So we actually had to warm it up before we gave it to him because he had warm and cold antibodies in his blood. Been a nurse 8 years, never done that. Didn't know what it looked like, didn't know the first thing about it. I pulled the hospital policy, read about it, grabbed a couple things I knew I could get. Then I called the resource nurse and I said, look, this is what I got. I need you to come work with me because I've never done this before, okay? Completely acceptable to seek assistance, use those policies. So that way it looks like you're showing initiative in your own practice, right? You looked at the policy. This is what you know, but this is still what you're unsure of and you need help with. Avoid accepting gifts. Patients will give you things. Patients' family members will be so grateful for the care you give. They're going to bring you coffee. They're going to bring you cookies, donuts, things like that. If a guy gives you a check for $25,000, you can't take it. You got to give that back. Or if they want to make a donation, then you have to set them up with whoever's in charge of that in the hospital and they can make a donation to the hospital. Consider having malpractice insurance. A lot of nurses have malpractice insurance because they want to know they're covered. A lot of nurses are automatically covered through their place of employment. Not everyone. So you want to make sure when you're getting a job, you want to find that out. Do they cover you? Understand or use the nursing process. What's the nursing process? We talked about that, right? ADPI. Make sure you are using the nursing process. Follow standards of care. Avoid medication and treatment errors. How do we avoid medication treatment errors?
The checks.
That's right.
Yes, medication checks, scanning that armband, name and date of birth. Do you have any allergies? You got it, all those ways. Report errors, report issues, and then document. So if you have a patient that's having issues with their oxygenation and their heart rate, you're going to report it to the doctor. And then before the end of your shift, you're going to go and back time your documentation to the time that the issue occurred. And then you're going to document that whole situation. This is what I saw. This is what I found. This is what I did. I notified the physician. This is what happened afterwards. And then you want to follow up. So you want anybody else that comes behind you to say, oh, Mr. Jones had an elevated heart rate today. Trish called the doctor. They ordered an IV dose of metoprolol. She reassessed him an hour later. His blood pressure came down. He's perfect now. So you want to make sure you're documenting so that anybody else can come behind you and know what happened. Complete incident reports. So if your patient has a fall or you give the wrong medication or some type of harm comes to the patient, you need to complete an incident report. Help maintain patient safety. If your patient is a high fall risk, make sure you're assessing their needs. Make sure you're performing that fall risk assessment. Make sure if they're a high fall risk, they have bed alarm on, share alarm on, red non-skid socks, a sign on their door that says they are a fall risk. If there are aspiration precautions, put a sign on the door that says what kind of food they have, how they take their liquids, because you don't want anybody else to come in behind you and give them something that could potentially cause them to aspirate. And then always maintain confidentiality and privacy. So a nurse's best defense of any kind of license investigation, hopefully this never happens to you guys, but if it does, you want to make sure that you get early legal counsel. So get a lawyer early on, talk to him about what's going on, bring in any character witnesses or any expert witnesses that were there during the time that whatever event occurred, and then make sure you get a thorough preparation for all your proceedings. So make sure that your lawyer is preparing you for anything that can come your way and anything that you might have to do. All right, so the 4 elements of liability. So liability involves 4 elements that must be established in order to prove that malpractice or negligence has occurred. So you must have duty, breach of duty, causation, and damages. So duty is an obligation to use due care. So what would a reasonably prudent nurse do? And it is defined by the standard of care appropriate for the nurse-patient relationship. So again, staying in your lane, right? Only doing your standard of care, your scope of practice. Then you have breach of duty, which is failure to meet the standard of care. So the standard of care when we give IV blood pressure medicines is that we put a patient on a telemetry monitor because we're giving them an IV medication that's going to regulate their blood pressure. We know it can drop their blood pressure low. We know that if that happens, it can also affect their heart rate. So we want to put them on a monitor so that we can monitor their heart rhythm, okay? These are standards of care for giving an IV blood pressure medicine plus taking vitals every 15 minutes. Failure to meet that care, you just go in recklessly, you push that medication in, you don't put them on a monitor, and then you don't check their blood pressure again for 2 hours. You come in the room, the patient's laying on the floor. That is a breach of duty. Causation. Causation shows that the failure to meet the standard of care, which was the breach, actually caused the injury. Well, it did. Mr. Jones' blood pressure was 80/30, and he got up to go to the bathroom because normally he's independent and his blood pressure was too low. He fell, he hit the floor, he was on a blood thinner. Now he has a brain bleed and he's in a coma. This is how it happens. This is real life scenarios. And then damage. So damages are the actual harm or the injury that resulted to the patient. So 3 outcomes of malpractice litigation. So all parties must work towards a fair settlement. The case is presented to a malpractice arbitration panel, or the case is brought to trial. So sometimes it never even goes to trial. They just work outside of it. They come to a fair settlement. One person pays the other person, and all parties are happy and they all go their separate ways. Sometimes it has to go to arbitration. And then if they don't decide anything there, then it has to go in front of a court trial. So if you find yourself in a situation where you are a nurse defendant These are just some recommendations. So do not discuss the case with those involved in it. Keep it to yourself. Don't discuss it. Don't alter any patient records thinking that you can cover something up or make something better. Cooperate with whatever your attorney wants you to do. Be courteous and professional on the witness stand, and don't volunteer any information that isn't asked. Hopefully you guys never have to experience that. Collective bargaining. So these are legal safeguards for nurses. So collective bargaining is a legal process in which representatives of organized employment negotiate with employers about wages, hours, conditions. So an example of collective bargaining for nurses would be the State Nurses Association, okay? Competent practice remains the nurse's most important and best legal safeguard. Competent practice. Each nurse, all of you are responsible for making sure that you are, that your educational background and clinical experience are adequate to fulfill the nursing responsibilities that they explain to you in your job description. Informed consent or refusal. This is every person's right. They're granted freedom from bodily contact by another person unless they give their consent. Contracts. Contracts is an exchange of promises between two parties. So this would be your employer and the nurse. So we, as the employer, agree to do X, Y, and Z. You, as the nurse, agree to do X, Y, and Z. Collective bargaining, we talked about that. Patient education. So U.S. courts do affirm that the patient's right to know what is necessary to manage their health and view patient education as a legal duty of nursing. That is one of the biggest things you do. You don't even realize you're doing. You're educating the patient, you're educating their family members, their loved ones, you're educating other employees that you work alongside, doctors, physical therapists. You are an educator, first and foremost. Executing physician's orders. So nurses are responsible for carrying out the orders of the provider in charge of a client unless a reasonable person would lead to injury. So if it is something that you think is going to cause the patient harm, you do not have to do it. You are advocating for your patient. There are certain steps you have to take. There's a chain of command. You would obviously want to get another nurse involved, get their opinion. You would want to call the charge nurse in. And then if it was something that everybody thought was unacceptable, then they would use that chain of command to speak to another physician or to that physician to see if this is why they are so passionate about having this order brought about. And then our documentation. It must be factual, it must be accurate, it must be complete and entered in a timely fashion. So remember I told you, when all hell's breaking loose and your patient is decompensating, you're not going to take the 5 minutes to write a note about what's happening. So what I do is I always write down on my piece of paper what happened. Just real quick, what time it was, 10:35, so that I know when I go back at 7:30 at night, when that's the first time I've had to document, I will document in that correct time, because they want everything to be in real time. So, safeguards to having a competent practice. So you can develop and maintain interpersonal communication skills. There are studies that have shown that a lot of malpractice suits come about because of a lack of communication. And in nursing, you have a lot of communication with your patients, with their family members, with other members of the healthcare team. So there always needs to be competent interpersonal communication skills. You need to respect legal boundaries of your practice. Stay in your lane. Only do what your scope of practice says. Follow institutional policies and procedures. So if your institutional policy says that when you give an IV medication that your patient has to be on a telemetry monitor and you have to do vitals every 15 minutes, you need to put them on a telemetry monitor and you need to monitor their vitals every 15 minutes. So know your policies. If it's not something that you know, make sure you pull that policy. Because if something happens and you say, oh, well, I didn't know the policy. Well, it is your responsibility. They educate you through your orientation and tell you about this tab that says policy and procedure. So you need to know what you're supposed to do. Owning personal strengths and weaknesses, seeking means of growth, so education and supervised experience to ensure continued competence for new and evolving responsibilities. So you have to own your weaknesses. We are not great at everything. There are some things that you're not good at, but other things that you excel in. But you need to know what your weaknesses are, because that's the only way you're going to grow. Each year at my job, we have to give a list of things that we think we're really good at. And then they also want to know what our goals are for the next year. So I always have to look and see what I'm really not good at. What do I want to be better at? And that is an uncomfortable situation sometimes, but no growth ever comes from being comfortable. And then, like I said earlier, keep going back to school, contribute to the nursing profession by being educated. Keeping current in nursing knowledge and skills. Nursing is always evolving. Evidence-based practice is always changing. So join those American Association nursing societies, become certified, know what the current knowledge is. Respect your patient rights and develop a rapport with your patients. Treat them like you would want your family members treated, or how you would want to be treated. Work within the facility to develop and support management policies. If you think something is broken or it's not working well, it's not supporting you or your nurses or your patients, work with upper management to develop new policies. And then again, keep careful documentation. All right, so more legal safeguards for nurses. So adequate staffing. Some people call it understaffing, some people call it short staffing. I feel like nursing and short staffing goes hand in hand. Just like antibiotics and probiotics, this is something that you always hear. There's always a nursing shortage. There's been a nursing shortage for like 45 years. There's still a nursing shortage. So sometimes you don't always have adequate staffing. When you don't have adequate staffing, this reduces your quality of care that you can provide, and it may jeopardize patient safety. A lot of things can cause staffing issues. Sometimes you might have to float to another unit that you're not used to working on. Nurses might have to work overtime. If a nurse doesn't come in the morning, you're legally obligated to stay, because you can't leave the patient. You can't abandon the patient. You might have to do back-to-back shifts. Things like that can affect staffing. Professional liability insurance, we said that this is a good safeguard for you guys. To have that professional insurance. Risk management programs, these are things that are offered by your employer. So safety programs, product safety programs, quality assurance programs. Whistleblowing. So whistleblowing is a warning from a present or a past member of an organization to the public concerning a serious wrongdoing or a danger created or masked by an organization. So if they see that something really bad is going on over and over and over again on a unit, someone can be considered a whistleblower and bring light to the situation. We talked about incident reports, also called variances or occurrence reports. These are used in healthcare facilities to document the occurrence of anything out of the ordinary. So most employers have what they call a just culture. They want anyone in the hospital to be able to fill out an incident report about anything that could have caused harm, that did cause harm, without the fear of losing your job or being retaliated against, because they believe that in a just culture, if they recognize the issues that are happening, they can further do what they call a root cause analysis and look at what should have happened, what did happen, what can we make happen in the future. This is how they solve problems, and they keep bad things from happening in the future. But if they're not reported because they feel like they're going to lose their job or they're going to get in trouble, then you don't ever, you don't ever solve these issues, and patients or staff members still continue to get hurt. Let's see, sentinel events and never events. So these are the expected occurrence that involves death or serious physical or psychological injury. Patients' rights, we know what patients' rights are, right? What they are, what their responsibilities are, and what their rights are, and what their expectations are. And then Good Samaritan laws. So Good Samaritan laws are designed to protect healthcare workers, healthcare providers, when they give aid to people in emergency situations. So you're going down the mall, sidewalk, and a lady falls over, grabs her chest, and she goes unconscious. You're the first person there. You start giving her CPR because she stops breathing. She has no pulse. You can provide care for that patient without fearing legal suit, okay? Unless you've done something really horrible in a grossly negligent manner, then you could probably be held accountable. So that's the Good Samaritan law. All right, information contained in incident reports. So we said when a patient falls, or if there was a potential accident, a potential harm to a patient or an employee, you want to do this incident report. So in the incident report, you always want to complete the name of the person and the name of any witnesses if there were any. You want to give a factual account of the incident, no type of opinion at all, just the facts. You want to have the date that it occurred, the time, and the place. So was it in the parking lot? Was it in room 324 on unit 45? Pertinent characteristics of the person involved. So Mr. Jones, I walked into the room, he was laying on the floor. Before that, we had given him 5 milligrams of IV metoprolol, IV, but he had his high fall risk socks on. He didn't have a bed alarm. All the pertinent information about that involves that situation. Any equipment or resources that were being used, any other important variables, and then you want to make sure documentation by the physician of a medical examination of the person involved. So if a patient falls, you always want to call the doctor and make sure that they come and look at them, put their eyes on the patient, and make sure that the patient is okay. As the nurse, you would do a set of vitals, right? If he hit his head, maybe you're going to do that detailed neuro assessment, right? That you guys learn to do in your physical assessment. Check out their eyes, make sure that they're dilated, check their neuro strength, stuff like that. And lastly, the Good Samaritan Act. So we talked about that you could do it without the fear of having any type of lawsuit brought to you. So every state has Good Samaritan laws, but through state to state, they vary considerably. So some nurses are covered in some states, but not in others. In some states, only certain acts are covered. So it's good for you to know in the state that you live what your Good Samaritan Act is. So in many states, there's no obligation to help, okay, except in like employment situations if you're working. And a healthcare provider, like anybody else, may choose to help or leave the scene of an emergency. Other states consider it mandatory that if you are a healthcare provider, that you have to stop to help. You need to know as an LPN what your law says. In many situations, nurses may have an ethical responsibility to assist in the event that healthcare providers assist a person in an emergency situation. When it's impossible to obtain consent for care, okay, the patient's unconscious, we can't ask them, is it okay if we do CPR? They are expected to use good judgment, okay, and to determine that the emergency exists and to give reasonably prudent care, okay? But that also, hopefully you won't be held responsible unless there's gross negligence. You guys need to know about the Good Samaritan Act. You're going to see that on your exam. So you guys need to know what your state says. And that's it. Your last lecture for these 2 classes. You're completely done other than your exam. Aren't you